Kinase inhibition in AML is rather more complex than kinase inhibition in the chronic leukemias. In inhibiting BCR-ABL in CML or Bruton's tyrosine kinase in CLL will give you a durable, dramatic response, whereas inhibiting a single kinase in AML, less so. And that's because there's no given kinase mutation that can fully transform a cell and turn it into an AML cell. So any inhibition is going to lead to a partial response. So it's more complex. The first drug across the finish line is Midostaurin, a rather broadly targeted agent, but there are much more selective agents that are actually nearing their completion of their pivotal studies. How to incorporate these agents and when, which ones to use, under what circumstances at diagnosis, maintenance phase, relapse, after transplant, is, I think, where the field is going. We have a number of pivotal trials studying those exact issues. However, incorporating these drugs into the conventional treatment regimens is less easy than it sounds. You don't just toss it in and stir. I'll show some data that, in fact, it's rather more difficult to inhibit the target in the setting of following chemotherapy than it is when you give the drug by itself. And so these present logistical challenges, pharmacologic challenges, as well as just the basic biology of which kinase to inhibit.